Hello everyone, welcome to Pediatrics by Dr. Anand. In this topic, we're going to talk about very important, one of the very important neonatology topic, that is nothing but respiratory distress syndrome, part 2. In this segment, we're going to talk about respiratory distress syndrome, part 2. Part 1 we covered in the evening. Uh, at least around 12 to 14 MCQs usually come from this topic. So that is why it is important for us to finish this topic. It's a very simple, happy, wonderful topic, and we'll try our best to make it as interactive as possible, and we'll try our best to make it understandable for everyone. My name is Dr. Anand. This is the Unacademy platform, and we're gonna start the what you called neonatology, and the subtopic is nothing but respiratory distress syndrome, part 2. For the newcomers, my name is Dr. Anand, and for the newcomers, if you are first time visiting our site, in Unacademy we have something known as Plus subscription and something known as Iconic subscription. In the Plus subscription, you get all the access to my live and recorded classes on YouTube as well as on the Unacademy app, and also on the Unacademy you get the best chance to meet and to listen to all the top educators all over the India. And also on this app we have the amazing live and test discussions. You can watch me on Android, on iOS, on your laptop, and n number of MCQs, like amazing MCQs we have, which I have made for pediatrics. It will be wonderful for you if you participate. So this was the Plus subscription, and now we have something known as Iconic subscription. In the Iconic subscription, you get the Unacademy subscription as well as the Prep Ladder subscription. As you know, Prep Ladder and everyone, we are now just one. So you get all the clinical notes, video lectures, question banks, rapid revision, dream notes, everything you get on the Iconic subscription. Okay, so please remember, and we have a special class, like this is a YouTube class, and we also have special classes free of cost which we are conducting. At least some 40-50 special classes we have done, and it's going super hit, and thank you so much everyone for making it super hit. The special part of special classes are, number one, we make it as interactive as possible. We have a option of putting MCQs and polls during the session. You can ask me any doubt at that time. You never miss my class in special classes because all the lectures are recorded, and also at the same time you get the notes, PDF notes, files, whatever I write, those things you get. Hello everyone, how are you, what's up everyone? So, and we have this updated and highly effective question bank based on the latest exam patterns and including the detailed explanation. And also a wonderful congratulations to our NEET PG September 2021 students. Beautiful people had participated, and they are the top rankers. And now we have the new, like at the March 12 2022, this our NEET PG. So we have wonderful toppers which I can now only I can tell, like Isha Srivastav, Hamid, Combat, and Subhangi. We have so many amazing students who are already participating in my lectures, and I think they are the top ranker students for me. And also every Wednesday, we have this free test every Friday, Saturday, and Wednesday. So it will be easy if you participate in as many tests as possible. I always tell all the students to participate as much as possible. Hi Subhashmita Sahu, how are you, what's up? And also we have made a batch of the target next integrated system wise batch, which basically starting on 8 December. It will be for 18 months, where we'll be talking about bilkul, step by step, system by system, and which will be helpful for the next 2023 students. Basically, we have made a wonderful batch. And one batch is already running, that is NEET PG 2022, and which already started, like gonna start from 8 December. We have already made a batch where we're gonna talk about everything: test and discussion, ultra fast revisions, MCQs, everything whatever you need is there on Unacademy. Okay, that's it. And Plus an Iconic subscription I have told you, and this is the code Dr. Anand. Like, for if anyone who is financially, it will be, if you use this code, it will be financially helpful for you. If you use this code, you'll get some concession, and it will be easy because you are a student, and in student life I can understand we all have our own commitments. That's why. Okay, so let's start. My name is Dr. Anand. Let's start the beautiful what you called point of the respiratory distress syndrome, part 2. This is the part 2. Part 1 today evening 4:30 we have discussed. It is the part 2, so it's going to be a very small and sweet session, but of course we will revise also a little bit of the part 1, and you please everyone try to participate as much as possible. Hi Subhashmita, Priyanka, Gautami. We have new people now today. Gautami, Rachna Rana. Okay, very nice. Very good to see you everyone. And Priyanka Sani. Okay, yes, Priyanka, I will surely, what do you call it, take your doubt. But before that, whenever we start, we always have a motivating quote. Today's motivating quote is before starting the batch, be strong. Be strong, but not rude. Be strong, but not rude, and be kind but not weak. This is the quote for today. Be strong but not rude. Be kind but not weak. So, this is the morale of life. Be strong. I tell everyone to be very, very strong in your concepts, in your focus, in your vision of life, but don't be rude. You know, like have your own journey, have your own path, have your own focus, but don't disrespect anyone, don't make anyone inferior. God has made everyone very beautiful and everyone is unique in their own aspect. So that's the main part. Be strong but not rude, and be kind but not weak. Be kind, be kind. Like I am a person, I am very kind by nature, I'm very humble. Everyone loves me. My starting from my gym instructor to my guitar classes to my sisters in my ICU and to my juniors and my study mates, everyone think I am humble, but I'm humble, but I'm not weak. I'm not weak. So that's life. So be strong but not rude, and be kind but not weak. Okay. Yes. So let's start the topic. Already we have already questions coming here and there. Hello Jatin, hi Isha, and hi Priyanka. So first question, Priyanka is already asking a doubt. So do we give any antibiotics in meconium aspiration syndrome? Yes, in meconium aspiration syndrome, usually, yes, when the baby has taken meconium, we give antibiotics. We give antibiotics at the same time we send the septic screening also. But in general, yes, we give antibiotics if the baby is clinically not good, if the baby is clinically not stable. If I see naturally you'll give antibiotics. Why you will give antibiotics? Did we read that if the baby has swallowed the meconium, it will go into the lungs, causing hyperinflated chest. What are the X-ray findings did we read in the evening? Hyperinflated chest with patchy infiltrates. Even it can cause a air leak. Yes or no? पढ़ा था हमने शाम को that it can cause proximal obstruction or a peripheral obstruction in general. So yeah, in meconium aspiration syndrome, remember we can give antibiotic. We should give antibiotics because one of the complications of meconium aspiration syndrome was emphysema, atelectasis, ventricular ventilation perfusion mismatch. So all because of all those things, we should give antibiotics in meconium aspiration syndrome. Yeah, because of chemical pneumonitis. Done. Priyanka, I hope your doubt is clear, because in meconium aspiration syndrome, baby can land up into multiple complications, right? Did we read in the morning, right? Air leak and bronchiectasis, atelectasis mainly, basically, and air trapping, emphysema, so important. So antibiotic देना बनता है, okay? Okay. Priyanka is again asking a doubt. Which antibiotic? If Priyanka, basically for any it's a good question, Priyanka. I'm really happy that you're asking question. Everyone is wonderfully allowed to ask doubts in our session. So Priyanka, antibiotics will go same like neonatal sepsis antibiotics. You remember we had read neonatal sepsis. In neonatal sepsis, we have first line antibiotic, we have second line antibiotic, and we have third line antibiotic. Yes or no? पढ़ा था कि नहीं पढ़ा था हम neonatal sepsis में? So that's what. So MP Genta is the first line antibiotic you can give, ampicillin and gentamicin. If the baby is not responding, instead of gentamicin, you can give amikacin. Yes or no? That comes in second line. Ampicillin will cover the gram positive organism, whereas gentamicin will cover the gram negative organism. Genta will be, ampicillin and gentamicin, yes, Isha, will be our first line antibiotics. Later, second line, if the baby is not responding, you can give, instead of gentamicin, you can give amikacin, and instead of ampicillin, you can give cloxacillin. Yes or no? पढ़ा था कि नहीं पढ़ा था? We have the same antibiotics which we read for neonatal sepsis will be same here also. And third line में क्या था? Third line, anyone? Third, Isha बताएगी. Isha, bro, dude, bro, I'm saying, Isha, third line antibiotic क्या था neonatal sepsis में? Do you remember? Did we study together? 25, 30 videos we have done on neonatology. If you are anyone is a newcomer, please watch those videos if you want to really crack the top rank in NEET PG. So third, very good. So third line antibiotic was Piptas. पिप्टास. What is पिप्टास? Have you heard of piperacillin and tazobactam? Yes or no? पढ़ा था कि नहीं पढ़ा था? Yes or no? Piperacillin and what do you call tazobactam? That's a third line antibiotic. And then we had the reserve antibiotics. Can anyone tell me the Isha again? The reserve antibiotic पढ़ा था Isha? Then we had another new Maya Devi. Nice, I know the name. So have you heard of meropenem? Have you heard of imipenem? You know, meropenem, imipenem, estrionam. Isha, you must, everyone, you must revise. Rachna, Gautami, Priyanka, Isha, and Maya Devi. You must revise our previous videos. Every day I tell you that it's good to participate in all my videos. That's very nice of you. But रात को सोने से पहले at least 1 hour, please revise in 1.5x or 2x. You revise all the videos, okay? Because they're important, dear. They are important. They will come in exam. So that's, I hope your what do you call it? Who had asked the doubt? Priyanka, doubt clear हो गया आपका? Can we move further? Priyanka, is your doubt clear? Can we move further? We give antibiotics. Which antibiotic? Depends. First line, second line, third line. First line is MP Genta. Second line is cloxacillin and amica. And third line could be piperacillin, piptaz, piperacillin, tazobactam with amikacin. Done. Can we continue further? Thank you. Today's topic of choice is respiratory distress syndrome, which is also known as what you call hyaline membrane disease. Okay, so what all did we cover in the first part? In the first part, we covered that there was a 1-day-old baby who was 30 weaker. Now listen carefully. Okay, now put all your good vibration in this class, please. Please connect your soul with my soul so that we can together achieve this journey and together we finish this topic. So 1-day-old baby who was a 30 weaker, less than 37 weaker is a preterm. So it's a 30 weaker baby. Normal vaginal delivery came with distress. How do you approach? That was the first question in the evening. I had asked you this question. So in general, then I also discussed the various causes, but I'll be going in little speed, okay, because this is the first part we have covered. That's why I will go in little speed. A baby is having distress. A 30 weaker baby is having distress. Of course, like as our topic is hyaline membrane disease or respiratory distress syndrome, so yes, in the lung parenchymal disease like HMD or RDS is the answer if we talk about baby having distress. But baby having distress, 30 weaker baby having distress has 1,000 more differential diagnosis, which we covered in the first evening part 1. We had, there could be a problem in the upper see, baby having distress, okay, baby having distress. So why distress? So number 1 could be a upper airway obstruction in and can anyone tell me what did we study in the evening about in upper airway obstruction? We studied about the choanal atresia. Yes or no? It could be a choanal atresia, that is why baby is having distress. Could be a micro in the oral cavity we covered, that could be baby is having microgonathia, or could be having macroglossia. See, baby having distress, okay, baby having distress. So what is the cause? Number 1, choanal atresia. In the evening we had covered. I'll show you a photo of choanal atresia. One second, where is the photo? Where is it? Yeah, this is the choanal atresia. याद है कि नहीं याद है? हाँ, failure to pass a nasogastric tube because there is a bony obstruction here and easy to pass a orogastric tube. So that is nothing but choanal atresia. Okay, so अगर if I'm not able to pass a nasogastric tube because there is a obstruction here, baby will have distress. याद है कि नहीं याद है? हमने ये पढ़ा था, हमने इवनिंग में अच्छे से पढ़ा था. Very good, Isha Srivastav. Isha is answering very nicely. Yes, Faiz also was there. Yes, bro. Very good, Faiz. So the baby was having distress other than hyaline membrane disease. The points which we covered are, let me just put in one full this one. Yes. In the upper airway obstruction, we studied about the choanal atresia. If there is a choanal atresia, baby will have distress. In the eyesight, my ophtha HOD told go from cephal to caudal. The causes of distress in a baby from cephal to caudal are: number 1, nasal problem, choanal atresia. Number 2, oral cavity, macroglossia or microgonathia. Macroglossia means large tongue or big tongue, and microgonathia is small chin. These two issues can cause distress. Then coming little neck. Neck में क्या हो सकता है? If there is a congenital goiter, baby will have distress. Next little थोड़ा नीचे आ जाओ. Larynx and laryngeal web, laryngomalacia, laryngeal stenosis, any vocal cord paralysis. Everyone, there's nothing to cram in this. Don't ratify line by line. I'm just giving you overview. The topic is hyaline membrane disease or respiratory distress syndrome, but I'm giving you a overview that these all things can happen. Okay. Yes, Isha is asking, sir, in upper airway obstruction, can a foreign body in a baby can cause distress? Yes, my dear, definitely. Foreign body, if a baby has taken, definitely it can cause distress. Definitely, it can definitely lead to distress in a baby. But just imagine, Isha, it's a newborn, na? It's a newborn, 1 day old baby, 2 day old baby. A 1 day, 2 day old baby, foreign body वैसे तो नहीं करेगा. Usually a child, 2 year old baby, 4 year old baby took a 5 rupees coin like that. A child usually comes to us with a foreign body, not a newborn. But good, you put a point that foreign body aspiration or foreign body content can cause distress undoubtedly. Isha, I have a question for you here only. Foreign body, Isha, is it common on the right side of the trachea or the left side? Is right side foreign body are more common, or the left side foreign body aspiration or foreign body going into the trachea is more common? What do you think? Everyone, please put an answer in the comment section. We have so many viewers, we have so many online people. What do you think? Anyone? Okay, very good. Faiz Ibrahim says right side it is more common. Okay, anyone? Yes, exactly. Priyadarshini is right. Isha is right. Ravi Raghul. Vanilla. Thank God. New names are coming. New names are answering. Means new names are the ones now who are going to crack this NEET PG exam by hook or crook. Yes, we all know that the right side of the angle, the right side of the trachea angle is little straighter, whereas the left side is little obtuse. Left side is like this, has a bigger angle. That is why left side foreign body aspirations are less common, and right side baby a baby ingested 5 rupees coin or a moti एक बच्चे ने मुंह में डाल लिया, so right side is going is more common. Then finish. So these are the points of what you call baby having distress. You please be connected with me, everyone. Connect with me. You know, I strongly believe Lord Buddha quotes, and I strongly believe this power of positive energy. So whatever you want to become, you will become. It's like you just have to believe that you are there. That's it. You just have to believe that you got a rank. You just have to believe that. Once you believe it, automatically things will gonna happen in that process. It is known as laws of attraction. So you connect with me. A baby having distress. So we covered the upper airway obstruction causes. We covered baby having distress. Baby having, there are 1,000 causes of baby having distress. If the baby is a preterm, of course it can cause something known as respiratory distress syndrome because of surfactant deficiency, which we discussed in the first part in the evening. If a term baby having distress, then the cause could be transient tachypnea of a newborn, the details of which will be in another proper webinar. Just the name for today, the most commonest cause of distress in a term baby is transient tachypnea of newborn. And if it is a post-term baby, then it is meconium aspiration syndrome. And pneumonia or atelectasis like lung collapse or air leak can happen in any conditions. And then last, the less commons are persistent pulmonary hypertension of newborn and bronchopulmonary dysplasia. Less common these people are. Developmental disorders also we covered in the first part, that what you called diaphragmatic hernia, congenital diaphragmatic hernia. The baby comes, the baby can have distress, any pleural effusions, and then we discuss the non-pulmonary causes, like baby is in failure, baby will have distress. So there are 1,000 causes. There are 1,000 causes of newborn having distress. You just have to open your brains and literally analyze, and you get it. Then we also covered in the first part incidence. In the incidence we covered that more the baby is a term baby, the chances are less. More than 37 weeker baby agar hai, the chances of him going into distress or respiratory distress syndrome are less. If the baby is less than 28 weeker, if the baby is चिकन आपके लिए रखना है, चिकन नहीं मैंने खा लिया, नहीं रखना, दे दो, नहीं खाना, सॉरी। क्या कहते हैं वो, If the baby is less than 28 weeker, if the baby is less than 28 weeker, there are 80% chances. There are 80% chances of that baby having distress. क्यों sir? ऐसा क्यों? Can anyone tell me? More the baby is preterm, why there are chances of baby going into respiratory distress? Because of surfactant deficiency. Sir, surfactant basically it is where the surfactant is present. Surfactant is present in the lungs. What is the function of surfactant? It helps in keeping the alveoli patent. It helps in keeping the alveoli patent. Okay, surfactant helps in keeping the alveoli patent. When there is decreased surfactant production, my alveoli will not be patent, my alveoli will not be open. ठीक है? And thank you Vanilla. क्या कहते हैं, my alveoli will not be patent because I'm having surfactant deficiency. I will have distress. So I will have distress. So there are 80% of chances that I can have distress if I have surfactant deficiency. Next, risk factors that also we covered. If I am a premature baby, I will have distress. If my mother is a diabetic, I will have distress. This again star mark we have covered. It's important. Okay, it's covered. If what do you call? Yeah, that's very true. Madhvan is very right. Jatin is right. Isha is right. Very good. If my mother is a diabetic, I can have distress. Why? Because maternal diabetes interferes. Maternal diabetes interferes with the surfactant production. Maternal diabetes, the mother is having diabetic, it will interfere in the surfactant production. So I can have distress. I can have distress. It's a very beautiful topic. कुछ रटने वाला नहीं है, मतलब समझने वाली बात है. It's a wonderful topic. There is nothing to cram. It's just you have to make a concept. अच्छा ऐसे होगा, ऐसे, अच्छा ऐसे, अच्छा ठीक है, ऐसे होगा, like that. Okay, yes, very good. So I'll repeat again. What are the risk factors? If the baby is a preterm, he will have distress. If the mother is a case of diabetes, the baby can have distress. What are the other causes? Genetic factors. Genetic, that's very important. Genetic factors are very important. If my brother also had a history of RDS, respiratory distress syndrome, then I also can have some features of RDS in a newborn period because genetic causes, right? And then very important, the last but not the least, thoracic malformation. Again, if I'm having a congenital diaphragmatic hernia, naturally all the intestine, congenital means by birth, this is the diaphragm which is supplied by phrenic nerve, C3, C4, C5. Diaphragm divides the thorax and abdomen. So congenital means by birth. Diaphragmatic hernia means protrusion of the what you called intestinal contents on the left side of the lung, left side of the thoracic cavity basically, and that is compressing the whole lung. This is the intestine, it is compressing the whole lung. So my lung is totally collapsed and kind of shrunken because whole intestine is sitting here. So I will have distress. Why you will have distress, sir? Because naturally एक lung तो गया ना मेरा, my one lung is gone, that's why I am having distress. So thoracic malformation, diaphragmatic hernia, or again genetic disorders, SPB or SPC gene mutation. SP is surfactant protein B, surfactant protein C, surfactant protein B, surfactant protein C. These all things what you called surfactant protein B and C mutation. So mutation matlab some issue, so I will have distress. These all are the wonderful causes or risk factors of me having respiratory distress syndrome. Did you understand this much, everyone? Please put a message in comment section or put a like button if you understood this much. If not, then let me know. Vanilla, Isha, Maya Devi, Madhavan Kutti, Jatin, Isha, Vanilla, and Priyanka Sani. Very good. And Gautami and Ravi. My dear friends, participate as much as possible. If you participate, you will remember more. You will remember more. मेरे को line by line आता है. I know line by line. I have done my MBBS. I have done my MD. I'm the youngest pediatrician who is teaching all over the globe. So I have done whatever I want. Now it's your turn. It's your turn to inspire the nation. So you try to connect and try to participate as much as possible. Next question. Yeah. Very important question. In the composition of surfactant, how the surfactant, composition of surfactant, basically the most important part in the composition of surfactant, what किससे बनता है, क्या होता है, तो we have something known as lecithin. Okay, what is lecithin? It's like surfactant. 68% it is made up of lecithin. 68% it is made up of lecithin. Lecithin का मतलब क्या होता है? डाईपोमिटाइल Phosphatidyl The name is written over here. Di Dipalmityl phosphatidylcholine lecithin is the major major component, which is having the what you called, which is a composition of surfactant. And also at the same time, the NEET PG question is, we have something known as LS ratio. LS ratio. What is LS ratio? Lecithin to sphingomyelin ratio. Lecithin to sphingomyelin ratio, it should be more than 2. If it is more than 2, the lungs are quite mature. LS ratio, if it is more than 2, yes, vanilla is right. Very good, Shubhangi, Geeta, Jatin, Maya Devi, Gautami, very good, very good, very good. So LS ratio should be more than 2. Sir, LS क्या होता है? Lecithin is to sphingomyelin. Sir, ये होते क्या हैं? These all are comes in composition of surfactant. These lecithin, sphingomyelin, all these are comes in the composition of surfactant. And in general, you should know, if the LS ratio is more than 2, means my lungs are mature. If the LS ratio is less than 2, my lungs are not mature. My lungs are not mature. Okay, very good, very good, Shahid Sohail. Very good. So in general, you should know that surfactant is composed of lecithin, which is nothing but dipalmityl phosphatidylcholine. Then it also contains phosphatidylglycerol, ethanolamine, and inositol. Phosphatidyl will remain the same. Phosphatidylglycerol, phosphatidylethanolamine, and phosphatidyl inositol. Okay, and we have other proteins, surfactant protein A, surfactant protein B, C, D, and lipids. So in general, I don't want you to cram line by line कि क्या क्या होता है बोल के. Don't cram everything. Just you should know lecithin. That's important. That's the 68% surfactant is made up of lecithin, and something LS ratio should be more than 2, means mature lungs. You have to do smart study. You have to do smart study. Don't do hard work. Do smart work. मोटा मोटा समझ के पढ़ना है, and whatever is important, you put a point on that. Don't write every word. Surfactant protein A, then B, then C, then D. Roughly you should know there are surfactant proteins, and main is LS ratio, main is lecithin. Done. Next. Yes, this also we have covered in the last class. Lungs do not collapse during expiration. Our lungs do not collapse during expiration because of the presence of West Bengal PG 2016. Anyone? Yes, we have covered in the evening class. Very good. Yes, because of dipalmityl phosphatidylcholine. It's because of that only, once I inhale, my alveoli expand. When I exhale, my alveoli kind of goes down, but they don't get collapsed. They still maintain some patency. That's for because surfactant, because lecithin helps in maintaining the surface tension. This lecithin helps in maintaining the surface tension of the alveoli. Okay, and when this thing is down, when this thing is not there, when this surfactant is deficient, then surface tension of the alveoli will not be formed, and it will cause collapse. It will cause collapse, and once it causes collapse, it will cause distress. Right? Next. So very important. Yes, that's the exam question we have already covered. 1 second. Yeah. 1 second. Yeah. That's another exam question. Surfactant is synthesized and stored. Surfactant is synthesized and stored in the type 2 pneumocytes. Type 2 surfactant is formed in the lungs. Where in the lungs? In the pneumocytes. Pneumocytes. There are two type of pneumocytes, type 1 and type 2. Surfactant is formed in the type 2. Surfactant is formed by the type 2 pneumocytes of the lung. This one line you need to understand. Star mark. It has been a NEET PG question. It has already been a NEET PG question. Surfactant is synthesized by the type 2 pneumocytes of the lung. And basically it's same story, no? Like, yeah, I mean, how, like, when there is surfactant, means my alveoli will be patent. My alveoli will be open. Surfactant helps in keeping the alveoli open. So, and it helps in preventing the alveoli collapse. It helps in prevention of the collapse of the alveoli. How it remains open? Like, number one, there is surface tension which is being maintained, and also like it helps in keeping it open by maintaining the FRC. This also we have done in the evening class. Can anyone tell me? It helps in maintaining the FRC of the lung. What is FRC? Anyone? What is FRC? Yes, very good. FRC is nothing but FRC is equal to FRC is equal to ERV plus RV. FRC is equal to ERV plus RV. In the evening class we have done FRC is functional residual capacity. Functional, yes, very good, Vanilla. Faiz, Isha, as much as you revise, dude, you will crack the seat, I'm telling you. So, whatever names are coming from my mouth, like Isha, Faiz, Vanilla, means these people will clear because you are doing hard work. That's why. Functional residual capacity is FRC is equal to ERV plus RV. ERV is expiratory reserve volume. Expiratory reserve volume matlab that once I'm taking, I'll show you a picture. Na? I think you'll get it better. This one, yeah. So this is expiratory reserve volume. This is the residual volume. So ERV plus RV is the FRC, functional residual capacity. So ERV, what is ERV? ERV is like this one thing is normal tidal volume. The normal I'm taking breath. This is normal tidal volume, 500 ml, right? And once I do this, so this which I totally blown my airway out, that is expiratory reserve volume. And still once I put all the air out, there is still some residual volume is left. So remember 1200 ml is 1200 ml is ERV, 1200 ml is RV, and total FRC is 2400 ml. 2400 ml. Total lung capacity is 6 liter. Everyone knows total lung capacity is roughly around 6 liter, and tidal volume is 500 ml, right? Very good, yes. And this is the IRV, inspiratory reserve volume. IRV matlab when I'm taking a normal breath, the pull which I took, that is the inspiratory reserve volume. That is the inspiratory reserve volume. Done. Next. Over this we have done it. Okay, I assume I are you guys with me? Are you connected with me? समझ आ रहा है कि नहीं आ रहा? हमने बहुत मोहब्बत से first part में पढ़ा था, and in even now also very beautifully we are covering to the point, logically and amazingly. Okay, and then we'll do the MCQs also. And always, yes, 5 things you will never recover in life. Number 1, a stone after it's thrown, a word after it's said, an occasion after it's missed, time after it's gone, and trust after it's lost. So these things you cannot recover in life. And for us, very important, time after it's gone. This time is really precious. Finish the topic, finish with me the whole thing, with whatever faculty you are doing, finish the syllabus. My only intention is transmission of knowledge, and I'm transmitting it to you so that you can transmit to your younger generation. Okay, moving further, the clinical features, baby having distress. Can anyone tell me clinical features? Isha, what are the clinical features of a preterm baby having distress? Should we connect with something, Isha, like clinical features याद करने के लिए मुझे क्या पता होना चाहिए? What should I remember? What you call to know the clinical features? Isha, Vanilla, Shubhangi, Faiz. What are the clinical features? So, sir, clinical features again, sir. The smart work will be, if a preterm baby is having distress, sir, you should just remember the Silverman Anderson score. Yes or no? You should just remember the Silverman Anderson score if a preterm baby is having distress, and you should remember the Downey's score if a term baby is having distress, है ना? These words are important, dear. These words are really, frankly speaking, they are important. In AIMS they have already asked a video question they have asked, not even a simple MCQ, video question. See the baby in the video and tell me what is the Silverman Anderson score, like that. और वहाँ लोग चक्कर खाए गिर गए, अयो what kind of question is this, like that. So you should know it, right? That's why I'm emphasizing again. Okay. Yes, the points of Silverman Anderson score we have already done, which is there are 5 points. We have upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunt. I assume you know this, everyone, guys. This we have covered multiple times in our previous videos. If you are a newcomer, please watch my previous videos and finish your syllabus. So there are 5 points of Silverman Anderson score: upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunt. Whereas in the Downey score, which is for term baby, this is Silverman Anderson score is done for preterm baby to assess the severity of distress. It is done for preterm baby. And what else? Yeah, so in the Downey score, which is done for term babies, उसके अंदर भी 5 point होते हैं. In that also 5 points are there in Downey score. 1 point is nothing but retractions. just retractions. In Silverman Anderson's code, they have divided into upper chest, lower chest, and xiphoid. But in Downey's, it is just 1 point. What you called retractions. Number second point is grunt. Same. So same. ये 2 point same है Silverman Anderson और Downey's के. और क्या points हैं? Can anyone help me? गीता, शुभांगी, माया देवी, रवि, राहुल, Faiz, Isha. Yes. So retractions are same. Grunting is same. The other points are cyanosis, tachypnea like RR, and air entry. These are the other points, and it is divided into 0, 1, and 2. 2 being very bad, 0 being normal. 2 being very bad, 0 being normal. Okay, remember what you called Apgar score also is divided into 0, 1, and 2, but 2 was very good. More than 7 is a normal Apgar score. More than 7 is a normal Apgar score. Okay, and here more than 6 score means baby is going into impending failure. Impending failure. We have to link and study. Are you with me? Yes or no? Remember, Apgar may, if it is the score like 0, 1, 2 is there in Apgar also, and 0, 1, 2 is there in Downey score, you say, or Silverman Anderson's, you say 0, 1, 2 is there. But 2 means bad. 2 means bad in the scoring system, Downey's or Silverman Anderson, whereas in Apgar 2 is good. 2 is a good score. Baby is normal. Baby is stable. And more than 7 is a normal Apgar in Apgar score, whereas more than 6 here means it's bad. Baby is going into failure. You have to put the baby on a CPAP machine. Like baby is having distress, no? Distress hai, RR more than 80, cyanosis, retraction, grunting. Baby is kharab, baby is bad, no? So what to do? You give, either you give oxygen or you give CPAP. What is CPAP? Continuous positive, continuous positive airway pressure. Done. Next, continue. Yeah. How do you diagnose? Now, who will tell me? Anyone? Gautami, Isha, Vanilla. How do you diagnose a baby of respiratory? अयो कहाँ चला गया? How do you diagnose a baby of respiratory distress syndrome? Any random guesses? कैसे करते हैं diagnosis? Anyone? Diagnose कैसे करना है? The baby is having respiratory distress syndrome. Number one, sir, either you can clinically diagnose it. Sir, by X-ray, I think it's good to diagnose by X-ray because surfactant deficiency, no, surfactant will not be there, lung will not be formed. So you'll kind of get a white out lung picture, white out lung. I'll show you the picture also, white out lung, है ना? So sir, clinically you can diagnose, by X-ray you can diagnose, and even by ABG also, you can diagnose because sir, but the baby is having clinically distress, no, distress, he is not able to breathe. Why is not able to breathe? Because surfactant is not there, no, so he is not able to breathe, right? So he is not able to breathe. So once he is not able to breathe, he will go into hypoxia. Not able to breathe, na. When there is decreased oxygen, there will be increased CO2. So hypoxia and hypercapnia and anaerobic metabolism will take place, lead to acidosis. So you will get the confirmation in ABG, the patient is going into metabolic acidosis, because whenever there is hypoxia or insult, whenever there is insult, there will be hypoxia, O2 will be less, so automatically CO2 will start retaining. So hypoxia, hypercapnia, and then that lead to anaerobic metabolism activation, and lactic acid is the one which gets started to form, and lactic acidosis or metabolic acidosis or shock, like that. Done. Yeah. Yes. So true. So in the X-ray, sir, क्या मिलेगा X-ray में? Very very important. I've already shown you air bronchogram. This पेड़ की तरह ये दिख रहा है आपको? Can we see that this line going here and there? So this one is nothing but air bronchogram. Air bronchogram. So this is the normal alveoli, where this is the bronchus, and we have the alveoli. This is the alveoli, and this is the vein, artery, and alveoli. Basically, alveoli are there. These all are beautiful alveoli around the bronchus. Beautiful alveoli. But now in hyaline membrane disease or respiratory distress syndrome, the baby surfactant is not forming. Surfactant is not there. Alveoli are not patent. Alveoli are not opened. In this normal thing, alveoli are beautifully open. ये beautiful open alveoli है. and whereas naturally alveoli will collapse, alveoli will not be there only. So kind of a, this kind of a white out lung, kind of a white out lung you will see. So typical X-ray picture of a hyaline membrane disease is white out lung, okay, white out lung, okay. And that's it. And it is also known as reticulogranular pattern, reticulogranular pattern. जो ये pattern है ऐसा, these all pattern is known as reticulogranular. इट्स लाइक अ मैच स्टिक अपीयरेंस, मैच स्टिक, माचिस की तीली होती है ना, ऐसा दिखता है। ये माचिस की तीलियां हैं एक तरह से, यूं समझो। दीज आर स्मॉल स्मॉल मैच स्टिक्स, दिस स्मॉल स्मॉल मैच स्टिक्स इज नोन एज रेटिकुलोग्रानुलर पैटर्न। एंड आई, एज आई टोल्ड यू, दिस इज नोन एज एयर ब्रोंकोग्राम ऑल्सो। सो व्हाट इज एयर ब्रोंकोग्राम? सो एन एयर ब्रोंकोग्राम लाइक दिस, नो, दिस one is, you can say reticulogranular pattern, you can say air bronchogram, anything you can say. So air bronchogram is a tubular outline, is this is the outline of an airway, ये airway ही है यहाँ पे, this is the airway made visible by filling of the surrounding alveoli by fluid or inflammatory exudate. Normally outside these what you called airways, there should be beautiful alveoli and beautiful black color lung, yes or no? But here there is no alveoli, no, there is no, like alveoli are filled with the fluid or inflammatory exudates. There is no normal picture. Why? Surfactant is not there, alveoli are not patent, they are collapsed, they are not even formed properly, so they are filled with inflammatory exudates and fluid. That's why this is known as air bronchogram, air bronchogram, ठीक है। ओपेक सर्कल दिस इज अ क्यूट क्वेश्चन, कौन बताएगा ये? हु हैज आस्क्ड दिस क्वेश्चन? ईशा। हाँ बताओ ये क्या हो सकता है? एनीवन? एनी रैंडम गेसेस? या दैट्स राइट। सो दिस इज द प्रोब, ईशा, दिस इज द प्रोब, दिस इज द यू नो, यू कैन से सेंसर, दिस इज द सेंसर of the machine. Like this neonatal warmer is there, no, neonatal warmer is there. So there is one probe, like you can say probe or a sensor, like you know, like I'll tell you, this neonatal warmer, we keep the baby in the warmer, okay, in the warmer ऊपर से heat आ रहा होता है, there is a heat coming. How much heat should I give? I will set the temperature in the warmer between 36.5 to 37.5, but at the same time, like exactly kitna, 36.6. If I want to give 36.6 only, then what will I do? I will put 36.6, but that warmer machine has a probe, has a plastic probe, you know, so has a wire kind of a thing. So that wire, one connects in the machine, and one like a probe, like this probe, I attach with a micropore, I stick it on the baby's sternum or a little on the xiphoid process kind of a thing over here. So means the warmer will only give 36.6 degrees Celsius temperature to the baby. If the baby is going little high temperature, the warmer will reduce the temperature. Means, are you understanding? Warmer will balance whatever I want to give to the baby. Warmer will only give that temperature to the baby. So it's like a sensor, or you can say probe, you know, for the temperature. This thing, this one done. अब समझ में आ गया ईशा? Did you get it now? Okay. So that's it. And typical, remember, yeah. So this reticulogranular pattern मतलब like a matchstick, माचिस की तीली होती है. So ये छोटे छोटे जो ये जो ऐसे 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 ये हैं, these are air bronchogram and like of a matchstick appearance. Okay, that's it, one thing. And also, you know, just I'll not go for too much stages of the, there are 4 stages in HMD, the X-rays wise, but just remember the stage 4 is the typical whiteout lung. The typical whiteout lung, like they are saying, in the beginning stage you will see air bronchogram, in the stage 3 you will get a very blurry diaphragm, in the stage 1 and 2 you will see in the stage 1, if you want to know too much in detail, in the stage 1 you will see reticulogranular pattern, which is nothing but, you can also say air bronchogram, which you say in stage, where is it? So this one, this is the stage 2, okay. So air bronchogram, can we see that this one like a air bronchogram? So air bronchogram in, you see in stage 2. I'll repeat again, reticulogranular pattern in stage 1, air bronchogram in stage 2, and stage 3 blurry diaphragm. In the stage 3 the blurry diaphragm also will start blurring out, and stage 4 typical whiteout lung, कुछ नहीं है उसके अंदर, ऐसा होता है। Done? Yeah, this is a very important question. Whiteout lung. Other than hyaline membrane disease, can you see white out lung in any other condition? Actually, this is a super specialty question, and in even once or twice in the rare question they have asked in NEET PG exams also. White out lung. Can we see white out lung in any other condition? So whiteout lung is seen in five very important conditions. Very important. Number one, of course, HMD, hyaline membrane disease, whiteout lung surfactant not forming and this and that. Number two, very good, infracardiac TAPVC. Very important, infracardiac TAPVC. What is TAPVC? TAPVC is total anomalous pulmonary venous connection. TAPVC is total anomalous pulmonary venous connection. There are three types of TAPVC. We have supracardiac TAPVC, supracardiac, cardiac, and infracardiac. There are three types of TAPVC. Are you with me? Yes or no? समझ में आ रहा है कि ऊपर से जा रहा है? हाँ. So फाइज ब्रो TTN में नहीं दिखता, ट्रांजिएंट टेकिपनिया ऑफ न्यूबॉर्न में डियर वाइट आउट नहीं दिखेगा, बट आई एम रियली हैप्पी डियर यू ट्राइड. White out lung is seen in hyaline membrane disease or respiratory distress syndrome. Other conditions where you see white out lung are like, just know at least right now, just know the names, why and all, like why sir क्यों मिलता है infracardiac TAPVC में. Once we study TAPVC in detail, I'll tell you why it is seen white out lung, because TAPVC itself is a 30 minutes to 1 hour topic. Once we do beautifully, like cardio is like my favorite, so like every topic is like I'm explaining nicely, but cardio also beautifully I'll tell you. There are three types of TAPVC: supracardiac TAPVC, cardiac TAPVC, and infracardiac TAPVC. What is TAPVC? Total anomalous means totally wrong pulmonary veins ka connection. Pulmonary veins ka connection. Normally in my heart we have this right atrium, right ventricle, left atrium, and left ventricle. Pulmonary veins comes from the lungs. Yes or no? Purified the blood, once it is purified, it travels to the pulmonary veins and go to the left atrium. Yes or no? Yeah, normally pulmonary veins travel from the lungs to the left atrium and they carry the purified blood, oxygenated blood. This is normal. This is normal. This is normal. Pulmonary veins are connected to the left atrium and from the lungs they are coming. This is normal. But total anomalous, totally wrong. Pulmonary veins ka connection. Pulmonary veins, instead of connecting into the left atrium, they are getting connected into the superior vena cava. In the superior vena cava. Are you understanding? Like there are three issues, okay? Either the pulmonary veins can get by mistake can get connected into the superior vena cava. Number two, see, one, the pulmonary veins are getting connected in the superior vena cava. Second issue, either the pulmonary veins can directly get connected into the right atrium. This is the second issue which can happen. And third, last but not the least, when the pulmonary veins are getting connected into the IVC, imagine here IVC, when the pulmonary veins are getting connected into the inferior vena cava, these three mistakes can happen in the developmental process. When the pulmonary veins are getting connected into the superior vena cava, that is known as supracardiac TAPVC. Supracardiac, मतलब दिल के ऊपर. Supracardiac pulmonary veins are getting connected into the superior vena cava, that is known as supracardiac TAPVC. When the pulmonary veins are getting connected into the right atrium direct, that is known as cardiac TAPVC. When the pulmonary veins are getting connected into the inferior vena cava or innominate vein, or just IVC, you remember inferior vena cava, that is known as infracardiac TAPVC. Infracardiac TAPVC. Okay. And what else? समझ में आ रहा है? इतना नहीं आ रहा? Are you guys understanding what I'm trying to tell you? So just remember, supracardiac TAPVC will have a figure of 8 appearance. That's another exam question. Where do you see figure of 8 appearance on X-ray? So figure of 8 appearance, or you can say snowman's heart. Snowman's heart. X-rays, photos, everything I'll show you, but only in cardio I'll show you. You are lucky I told you right now the theory part, but this is a cardio topic. So just I'm trying to tell you that figure of 8 appearance, we have figure of 8 appearance. Figure of 8 appearance is the NEET PG question. So supracardiac TAPVC, when the pulmonary veins are getting attached into the superior vena cava, on the X-ray it will look like a figure of 8, or snowman's heart, that is known as supracardiac TAPVC, whereas infracardiac TAPVC will present as white out lung. ठीक है? Yeah, that's Kaustup bro, did you understand? Yeah. Isha says cardio is very tough. Isha, cardio is the easiest, dude. कार्डियो इज द इजीएस्ट, कुछ नहीं है उसमें, बिल्कुल मोती की तरह आई टीच यू कार्डियो, कुछ भी नहीं है, इट्स वेरी इजी डियर, इट्स वेरी 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 इजी, इट्स लाइक easiest आई कैन एवर टेल यू इन द होल planet, इट्स दैट मच इजी। वैसे तो फॉर मी ऑल टॉपिक्स आर इजी, बट कार्डियो इज वेरी लाइक, अब मैंने ये पढ़ा है, टफ लगा क्या? आई टॉट यू जस्ट नाउ दिस थिंग, डिड यू फाइंड इट वेरी टफ टू अंडरस्टैंड? नो राइट? टोटल एनॉमलस, टोटली रॉन्ग। पल्मनरी वेन्स का कनेक्शन, pulmonary veins normally they enter into the left atrium, but in they could enter into the three issues which I told you। ठीक है, समझ में आ गया? So just remember that what you called figure of 8 appearance is seen in supracardiac TAPVC, but whiteout lung it is seen in infracardiac TAPVC, and infracardiac TAPVC is also known as obstructive TAPVC. That's why in my classes, if I ask you where do you see figure of 8 appearance, people say TAPVC, TAPVC, but a topper should say figure of 8 appearance is only seen in supracardiac TAPVC, because whiteout lung is seen in infracardiac TAPVC. So both are different, so both are totally different। ठीक है, that's it। ठीक है, ठीक है, कोई बात नहीं, आ जाएगा डियर, कोई प्रॉब्लम ही नहीं है ईशा, इट विल कम। बहुत आसान है, बहुत आसान है। एक बार नहीं आएगा, 2 बार, 3 बार, 4 बार, छोड़ना नहीं है। ट्राइंग 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 अंटिल यू गेट सक्सीड, छोड़ना नहीं है। वंस यू से कि नहीं मेरे से तो होगा ही नहीं, नहीं छोड़ना ही नहीं है। नहीं आया समझ में, दोबारा बाद में बता दूंगा, आई टेल यू अगेन, समहाउ दिस कार्डियो, दिस इज कार्डियो विल come again, so I'll tell you, chill। So the options, where do you see white out lung? The conditions are, let me just tell you the whole conditions. This is a super specialty question actually। So the condition where you see white out lung are hyaline membrane disease or respiratory distress syndrome, which I told you just now। Infracardiac TAPVC, very important। There is one condition known as PAP, pulmonary alveolar proteinosis, pulmonary alveolar proteinosis। Then fourth we have surfactant protein deficiency। Fifth, Isha was right, massive pleural effusion। And sixth is group B streptococci infection in newborn। My niece is shouting out। ये तो अब बात भी चिल्ला चिल्ला के करते हैं लोग, God। I don't know how to mute this button, and I can tell them to just little be quiet, but it's okay। So कहाँ थे हम? हाँ, these are the conditions where you can see white out lung, white out lung। So what you called? That's it. Next, yeah, this is a good question। Let's see if anyone can answer it। Isha, Shubhangi, Vanilla, Kaustubh, Geeta, and Faiz Ibrahim। Jipmer, May 2017। Jipmer, May 2017। A baby is born, a baby is born। थोड़ा धीरे बोलो, धीरे, कोई नहीं सुनेगा मेरे इस घर में। This is a chit chatting time, they all chit chat whole evening, that's what। So a baby is born, a baby is born premature, a baby is born premature at 29 weeks। A baby is born premature at 29 weeks by LSCS। एक बेबी हुआ है प्रीमेच्योर है 29 वीकर, बहुत छोटा है, by LSCS। ठीक है, LSCS done for fetal distress was there, okay। Neonate developed tachypnea, nasal flaring, subcostal, intercostal retractions immediately after birth। Chest radiograph shows bilateral diffuse ground glass। So whiteout lung is also known as ground glass appearance। Whiteout lung is also known as ground glass